Welcome, everyone, and thank you for joining for this evening's webinar, A Path for Pain Relief. We are excited to have Dr. Raymond Scholet here to discuss the patient journey and treatments available from medications to surgical procedures and beyond. Whether you're someone directly impacted by facial pain or simply interested in learning more, we're glad you've taken this time to be here with us today. My name is Brandy Underwood, and I serve as the Manager of Development, Research, and Advocacy for the Facial Pain Association. Before we get started, I would like to share some updates from the Facial Pain Association this month. October is Facial Pain Awareness Month, which is why I'm wearing this pin today. Throughout the month of October, the Facial Pain Association celebrates Facial Pain Awareness Month by honoring those living with neuropathic facial pain. The following days and conditions are highlighted during the month. October 7th is Trigeminal Neuralgia Awareness Day. October 10th is Geniculate Neuralgia Awareness Day. October 14th is Glossopharyngeal Neuralgia Awareness Day. And October 25th is Occipital Neuralgia Awareness Day. We will also host 3 webinars this month, starting with tonight's discussion featuring Dr. Scholet. Dr. Jonathan Greenberg will also join us to discuss the importance of mental health and facial pain. On October 16th, we're excited to welcome children's author Jackie Gauge, who will deliver her message of hope and talk about her experiences living with TN. We'll wrap up the month with a webinar on October 29th, where we'll host a panel of doctors featuring a neurosurgeon, a neurologist, and a radiation oncologist to discuss the management of trigeminal neuralgia. The Facial Pain Association today launched its second book in 4 years. One of our board directors, Ann Semnecki, is going to join us in just a minute to talk more about our new book. We are very proud of this book and its amazing content focused on living well with facial pain. We're incredibly grateful to Ann and to the Medical Advisory Board, Dr. Jeffrey Brown, along with guest editor, Dr. Beth Darnall, who's also a member of our Medical Advisory Board. Over 30 buildings, bridges, and monuments will also be lit up in teal to shine on neuropathic facial pain and show support for the facial pain community. Participating structures include famous skyscrapers, bridges, and sports stadiums to small-town village halls. In addition to today's book launch, and just in time for Facial Pain Awareness Month, we launched our online shop. If you click the shop button in the top navigation bar, you will see the newest addition to the FPA's website at facepain.org. You can purchase both books there, as well as the newly launched FPA Awareness Month t-shirt. Throughout the month of October, you can purchase the new book at a 10% discount. We're also offering a bundle with savings to purchase both books at once. We hope you'll help us spread awareness this month. If you are ready to share your story on social media, please do so and tag us so we can share it too. If not, please look for our content throughout the month on Facebook, Instagram, and X, formerly Twitter, and share it so your family and friends can learn more about facial pain. This month is incredibly important because it's our chance to let others know about facial pain, what it is, and how it affects our community. This is critical to our efforts toward quicker diagnoses and understanding the impact on the daily lives of those affected by it. Before we get started, I'm going to go over a few housekeeping items. If you have any questions for our presenters, please use the Q&A feature at the bottom of your Zoom screen. We will have a dedicated Q&A session at the end, but please feel free to submit questions throughout the presentation. And we encourage you to connect with other attendees using the chat feature. Today's webinar is also recorded and will be available on our website in approximately 1 week. Now, I'm excited to introduce Ann Semnecki, Secretary of the Facial Pain Association Board of Directors, an FPA peer mentor and support group leader, and co-editor of Facial Pain, a 21st Century Guide, as well as its new companion. Ann, I welcome you to share some information today about the new book.
Well, thank you, Brandy. I'm as excited as you are And in addition to being excited, there's this big sigh of relief. We made it by Awareness Day. Um, it has been my privilege to work on this book and to co-edit it along with neurosurgeon and past president of the medical advisory board, Dr. Jeffrey Brown, and also pain psychologist, Dr. Beth Darnell. The book is nearly 400 pages and has 40 different section authors, including our panelists today, Dr. Sekula and Dr. Greenberg. 8 other medical advisory board members contributed to the book. And I try and think of the book as a little bit like the story Stone Soup. Do you know that story?
I don't.
Oh, I'll have to tell you.
I know it.
You do? Good, good. So each of the doctors made unique contributions, and together the book was rich with evidence-based, accessible information for our community.
Mm-hmm.
So the book is not an update of our first book, and it's not a follow-up to topics that were in our first book. It's a companion volume, and all the information in the book is brand new, and it has the perspective of living well with neuropathic facial pain. I think you should have both books. Let me tell you a little bit about the content. The highlight of the book is the medications chapter by Dr. Wolfgang Liedtke. It covers all the different medications that people with neuropathic facial pain take, and he discusses rescue medications that we take when we need immediate relief, medications to control high blood pressure because that's key to keeping the pain down, maintenance medications that we take on an ongoing basis, even medications to manage and injectable medications. The chapter also includes, that's the very first chapter of the book, and it also includes a section on topical medications and Ketamine. There are people who think you might want to buy the book solely for this chapter. It is really a very, very important chapter. We also covered the different types of neuropathic facial pain in order to shine a light on the conditions that are often overlooked. And this includes glossopharyngeal neuralgia, geniculate neuralgia, and occipital neuralgia, along with hemifacial spasms, burning mouth syndrome, post-herpetic neuralgia, and anesthesia dolorosa. There's some brand new topics in the book too, like sleep, intimacy, familial neuropathic pain, and virtual reality for pain relief. That is such a fascinating chapter. We also include tips on applying for Social Security disability benefits. Right now, we have a softcover version and an ebook available on lulu.com. And if you click on a link on our FPA website, you'll be taken there. And thanks to a volunteer who's a professional voice artist, an audiobook will be available soon. As Brandy mentioned earlier, there's a 10% discount during the month of October and a discount for purchasing the bundle, both books together, if you don't have the first one. The sale of this book and everything else our FPA store supports the FPA's programs and initiatives. If you do not yet have the book and you feel you need a copy and you can't afford one, call the FPA office and we'll provide one to you. This isn't all about the money for the FPA. This is about spreading information and educating. So thank you all so much for supporting the books over the years. Thank you, MAB members and other contributors to the book, because editing was really the easy job. The hard job was writing the chapters in the first place. And I'll be thinking about book number 3 soon, and I'll share that information. This will be one where patients and their caregivers make the contributions.
Thank you so much, Anne. I know how much work you've put into this and getting to see just behind the scenes. And thank you is not enough. It's just not enough.
Oh, well, thank you too. You are our #1 proofreader.
That's okay. Yes, I had a very small part in it, but thank you.
A big
Thank you,
part.
Anne. Thank you so much, Anne. Thank you.
Okay, I'm just going to sign off now.
Before I introduce Dr. Sakula, I would like to introduce a special guest who's joining us this evening to speak about the mental health aspects of living with facial pain as we head into Awareness Month and the holiday season. Dr. Jonathan Greenberg, a research staff psychologist at the Center for Health Outcomes and Interdisciplinary Research within the Department of Psychiatry at Massachusetts General Hospital, and an assistant professor at Harvard Medical School. Dr. Greenberg also recently received a grant from the National Institute of Dental and Craniofacial Research for chronic orofacial pain research. Welcome, Dr. Greenberg.
Hi, thanks so much. Great to see everyone. Thank you so much for having me. So I'm here to discuss, talk a little bit about some mental health aspects of orofacial pain and chronic orofacial pain, and share a few of our research findings. Let me see if I can share my screen here and get some slides going. So hopefully you're able to see that. All right, so I'll try to keep it brief. So yeah, we were fortunate enough to be able to distribute 2 surveys through the Facial Pain Association newsletter. And we got a very good response. We got about close to 300 people at each of these surveys. And we got some really important information that we're using to leverage important research on the topic and develop an intervention to help people with chronic orofacial pain. This is from our first survey. What we're seeing here is like there are very high rates of mental health issues. And so 56% of our respondents reported clinically meaningful symptoms of anxiety, and 2/3 reported clinically meaningful symptoms of depression. That's a lot. I think right now we have 124. So that means about, I don't know, 75 of the people here on average would experience some level of depressive symptoms. Which on one hand is, it's bad news, but in a way, there's a lot of us in this. So we're not alone in this boat, and there's a lot of things we can do together to help. And I will share some resources in just a couple of minutes. Just over 1/3 are currently taking antidepressants. This is from our most recent survey. We see that 60% of participants reported thinking about their own death in the past 2 weeks. Just about a third reported having at least some thoughts of suicide, and 30% reported thinking that the world will be better off without them. That's pretty grim. And these aspects of chronic orofacial pain are under-addressed. So I'm sure many of you have experience with medical providers for chronic orofacial pain. I'm not sure how many address these issues, but they're very, very prevalent. So prevalent, astonishingly prevalent, really. This is also from a recent survey. 44% have risky substance use. So it's across different substances. The most prevalent substances were cannabis, opioids, tobacco, and sedatives. Risky substance use, we define it as substance use that has a greater likelihood of impairing physical function, mental health, or physical health. So a few things of what we can do about it. This is a bit of a shameless plug of the recent study that Brandy was talking about. This is our flyer. If you have chronic orofacial pain, and if you want to help us develop an intervention to help emotional and distress among people with chronic orofacial pain, let us know. The first step in our intervention development is a focus group. So it's going to be over Zoom for 1 hour. We're going to meet up with a few people that have chronic orofacial pain, and we're just going to ask you about your experiences, and we're going to learn from that and build an intervention to serve your needs. In order to help make that happen, let me see if I can. I'll plug it in the chat. I just plugged it in a chat now. So if you're interested, I just entered a link into the chat. It says, "Oh, do you consent to being contacted by the study team?" And if you are, enter your details. We'll contact you, talk to us for 1 hour, get paid $50, help us develop an intervention for people with chronic orofacial pain. Now, some resources. All right. First of all, obviously, the Facial Pain Association, they have a wonderful website. There's a bunch of support groups and there's facial pain information. I'm sure Brandy here and Melissa and everyone knows more about this. But other resources that you might find helpful, the American Chronic Pain Association, they have resources to get peer support, educational resources for people living with chronic pain. Also, if you are experiencing some mental health issues, some stress, anxiety, depression, it is common and normal for everyone, especially as we approach the holidays. It's particularly, it's more common among people with chronic orofacial pain. And if you feel that you do want to see someone, I'd highly recommend it. There's multiple places for us to find somebody that can help. Help is always available. You can find a therapist through American Psychological Association psychologist locator. I have the link here. I'm happy to drop that in the chat as well. Most of my patients, most of the people that are here are looking for a therapist. I just refer them to Psychology Today. Just Google Psychology Today to have a tool to find a therapist. You enter your zip code and you see all the therapists that are around. If you're feeling particularly distressed and if you're feeling that you might be in danger, you can always call 988. It's a suicide hotline. If you feel you're struggling with substance use issues, you can always go to the DEA. There's recovery resources in this link. I'm happy to share this slide with you. And that's just to say that you're not alone. There's always somebody to help. The awareness of mental health issues and chronic pain is really kind of emerging, and with your help, we'll kind of raise awareness to that. So thank you so much. I'll hand it right off to Brandy again.
Thank you so much, Dr. Greenberg, and also for always including patient voices in the research that you're doing. We appreciate your continued partnership in that. And just to say that, admitting that we might need help, even if it's mental health help, they can help you to cope with the pain and validate your experiences, including the fact that you're living with this facial pain. Thank you so much, Dr. Greenberg. Now, it is my honor to introduce Dr. Raymond Sekula, a professor of neurological surgery at the Columbia University Department of Neurological Surgery. He has published more than 100 scientific articles and is co-editor of the textbook Microvascular Decompression Surgery, a comprehensive look at MVD surgery, widely accepted as an effective remedy for cranial nerve hyperexcitability disorders, including hemifacial spasm, trigeminal neuralgia, and glossopharyngeal neuralgia. Dr. Sekula is also the chair of the Medical Advisory Board of the Facial Pain Association. Again, we are thrilled to have you here with us this evening and hope this session is helpful for you. Without further ado, let's get started. Dr. Sekula, please take it away.
Great. Thank you, Brandy. Thank you for organizing this evening. Really appreciate it. And congratulations on the book. I have some idea of how much work you put into that. And Dr. Greenberg, that was a terrific talk. And I'm so delighted that you've taken an interest in patients with TN. And for those of you on this webinar, it's an enormous amount of work to obtain funding through the National Institutes of Health. And it really helps that someone of Dr. Greenberg's ability is putting his efforts to patients with this disorder. So let me pull my apologize. I'm having a little trouble getting my talk up here.
Can you choose select window, Dr. Sekula?
I'll tell you what, I'll just start over and have you tell me, please. Apologize.
That's okay. When you choose select screen, if you have it up in the background, you can either choose window. It's still showing.
I'm going to stop sharing.
That's okay.
And
also, if you want to email it to me, I'm happy to click through it as well.
I would, but I'm just worried. There's a lot of videos and it might not.
Okay.
Is it allowed to share window, allowed to share screen?
You should be able to choose either share window or screen.
Okay. And then,
It should give you the options of application window at the top, documents, or advanced.
now, shoot. Oh, darn it. Shoot. I'm awfully sorry.
It's
I mean,
If you'll hit stop share there at the top.
yes.
Okay, and then when you choose share at the bottom, it's going to give you options. Like it's going to pop up in that first window, and you should be able to see what you're sharing before you share it. Do you have your presentation up on the background?
I do.
Okay, so when you first pull up share, click the green
Yeah.
button at the bottom.
Yeah.
Do you see the option?
It says allow to share window, allow to share screen, or don't allow.
That's all it's giving you the options for?
Yeah. I wonder if I need to be on a different browser. I'm on Safari.
You may need to be in Chrome.
Okay, I'll log out real quick. Maybe you all can talk while I do that.
Okay, that's fine.
Awfully sorry.
That's okay. I'll invite Ann back to talk a little bit more about the
Okay.
book.
Okay.
Ann, would you like to join us and talk a little bit more about the book while Dr. Scholet pulls up his presentation? You're muted, Ann. That's okay.
Okay. I'm not muted. Can you see me?
Yes, ma'am.
Oh, good. I can't see me, but that's okay. I'll just maybe move this away so I can see. There we go. Now I can see me.
Yeah. I can also welcome Dr. Greenberg back as well, if he would like to answer some questions, maybe that's come in from the audience. Thank you,
Yeah,
Dr.
sure. If there's anything about my presentation or about any resources, happy to chat.
You know, the book addresses a lot of mental health concerns, and we have a whole chapter on, including your work on pain psychology, and a nice chapter by Dr. Beth Darnell on, I have to think of what she calls herself, empowered relief.
Yes.
Where you can actually take a class that isn't really psychology, but it is skill giving. So you learn skills to help you cope with the pain.
Yes, and that is so important, because there's a lot of research in chronic pain in general. There's a lot less in chronic orofacial pain about the importance of psychosocial factors and about how mental health it impacts our facial pain, but it also is impacted by our facial pain, and it's kind of like the cycle. So even though there's some research showing how important it is and how prevalent it is, there's not a lot, but there's some. A lot of it doesn't trickle down to the actual clinician. So when you go to see your neurologist, when you go to see like your orofacial pain provider, they might not necessarily ask you these questions or pick up on that. So sometimes it might be up to us as like patients to go to our providers and specifically ask, you know what, this is the pain is, it's kind of getting me down. It's kind of impairing my function. It's, I'm having some interpersonal issues because of it. And by the way, these interpersonal issues, these are even more in trigeminal neuralgia than other orofacial pain conditions and other forms of chronic pain, because a lot of times in certain types of trigeminal neuralgia, the pain is very much unexpected. Right. And it's hard to predict when it's coming. It's sometimes for people with TMD, they're better able to predict. They kind of feel it coming, but it just zaps you out of nowhere, and that's very difficult for many people to kind of contend with. So they opt to what they do is they just kind of limit their lives. They just kind of avoid situations in which it might be problematic for them should they have this occur, and so this has an impact on their social life. Also, sometimes we heard from many people that talking is painful, which also impairs our ability to get support from our friends, even go to a therapy. So many types of therapy are talk-based, which is why the program that we're in the process of developing is not talk-based, so that people it will not be a barrier to receiving care.
Yeah.
I
And
think
the other
that's
thing is,
excellent. Accessible. Yes, just, talking about the accessibility there is fantastic.
touching and kissing and the importance of intimacy and it just feeling good is very difficult.
Yes.
You can't touch your face, you can't kiss. So what do you do instead? So we have a chapter in the book on intimacy and alternatives to touching and kissing.
Yes.
So that's a good chapter too. And
It
sleep is so important. You
is.
need sleep if you want to feel better.
Can certainly drive up, I think, the pain or the level of pain and your ability to cope with it too. When you're sleep deprived, it makes it harder to process or even to use the coping strategies that you have. They seem not to work as well.
Right.
Yes.
Okay, I'll try one more time here. I'm on a different browser.
Excellent.
It says choose what to share, Chrome tab window or entire screen.
Okay. Do you have your presentation pulled up in the Chrome tab window?
Should be.
Okay.
Why is it not doing it?
That's okay. Dr. Greenberg, while Dr. Sakula pulls that up, there is a question about the study. They're asking kind of about eligibility for the study. If their pain is random and intermittent, would they still qualify for the study?
Absolutely. We're pretty inclusive. So all you have to do is, all you have to be is 18 or over within the United States and have chronic orofacial pain, which we define as having pain in the neck, head, or face for more than 3 months. If you hit all these, you're eligible. And again, this is early intervention development. So the link that I shared right now is just a focus group. You meet, you talk with us for an hour, you get $50, you share your experiences. In the later phase, we're actually going to pilot the actual web-based platform. And hopefully you guys can benefit from that as well.
Excellent. And I've scanned that QR code and I'll share that out if you'd like me to with our volunteers, if anyone's interested or even in our community who might want to participate.
All right. Awesome.
Focus groups are just another great way to ensure that patient voices are heard.
Absolutely.
Yeah,
I'm glad
appreciate that. And Dr. Sakula, if you want, you can I was able to share my screen. So again, I know that if you have a file, you want to send it to me, I'm happy to kind of share it on my end. I know you have some videos and stuff.
I appreciate it. It's just too large to send. It won't.
Okay.
Yeah.
Okay.
All right. Well, I'm sorry, everyone. I'm not sure what else to do. I've not really had this problem. Any thoughts, Brandy?
Yeah, so we already have some questions coming in and just information wanting to talk about, different chapters of book. We can talk about the different medications. We can talk about surgical procedures, mental health. I think we can just have a holistic conversation here. We have so many wonderful people with us this evening, especially you, Dr. Sakula, if you'd like to turn on your camera and we can just talk through. And Dr. Greenberg, you can stay on and join us as well. And we can just have a great conversation. So,
Okay, great.
yes. So, good to hear about the chapter on medications in the new book. They're saying that few doctors or neurologists, they, know what to do when they reach the maximum dose of carbamazepine, and the side effects are intolerable. Is a case of trial and error on meds? And how do you manage after you've had, maxed out on carbamazepine, it's not working, or the side effects are too much to bear, what is your recommendations, Dr. Sakula, on really next steps?
Well, I mean, what I wanted to share tonight was kind of a rundown of the different types of facial pain and those types that some that are amenable to surgery and some that are not. So let me just get my camera on and forget about this. So I'm sorry about that, but
Okay. These things happen.
yeah. So, first off, it's important to try to understand what type of facial pain you have. So if you have a classical TN, then that means that you have the type of trigeminal neuralgia that is a sharp, intermittent stabbing pain. The attacks generally don't last more than 2 minutes. And generally, the pain is responsive to carbamazepine or oxcarbamazepine. Now, I just reviewed a paper from a group, and I think it'll be accepted for publication, where they're looking at the difference between oxcarb and carbamazepine, and it's looking like more people should start with oxcarb because it has less side effects, except for really elderly people, where it does tend to drop their sodium a little bit more than carbamazepine. But if you have classical TN and the medications aren't working, or their side effects are problematic, then I think it makes sense to be evaluated by a neurosurgeon and have them take a look at the proper MRI and see if you would be a good candidate. Primarily for microvascular decompression, because that's the most durable operation that we have. Now, in the newest classification schema, one should understand, though, that there's also something called idiopathic TN, and this all gets a little confusing. But the important point is that patients with idiopathic TN, they may have a blood vessel just touching their nerve, but they don't have a real deformation of the nerve. And so they still may be good candidates for microvascular decompression, but there's a lot of variables that depend on that. And you should really talk to someone that's really, expert in understanding these different conditions.
Yeah.
If you kind of run down the line, and this is sort of what I wanted to talk about tonight, of the different types of facial pains and how you treat them. So those first types are classical TN and idiopathic TN, and then another one that's important is the trigeminal neuralgia due to a secondary cause, and that can either be, for example, a tumor, or that can be multiple sclerosis, and they require very different treatments. So tumors that occur in and around the trigeminal nerve are usually benign, and they're usually well controlled, for example, with stereotactic radiosurgery using tools like the gamma knife or the cyber knife or something like that. And that's fine, except it's not unusual for a patient to have a tumor like that then, even though this gamma knife or cyber knife has arrested the growth of the tumor, the tumor continues to, the tumor begins to cause pain. So in other words, the patient will have a tumor that's arrested in growth, but it's just causing lots of pain. And sometimes those patients, actually oftentimes those patients are told, your tumor's not growing, there's nothing to do about it. And these people are in quite a bit of pain. And so I was going to show a patient today that, we went in and just removed the tumor, and they woke up free of pain and continue to be free of pain. The challenge, though, is when they've had gamma radiation first, then they have a pretty high chance of developing a lot of numbness after the procedure to remove the tumor, because the gamma radiation, while it's very effective at arresting the growth of the tumor, it does injure the nerve, and so then the nerve is does not really like the manipulation of the surgical removal. And then, so those are kind of the big ones under the trigeminal neuralgia heading. MS is different. MS does not respond to microvascular decompression. So you'll still see some reports of groups that have done microvascular decompression. They come with the conclusion that it didn't work. Well, we've known that for probably 40 years or so. So for patients with TN secondary to MS, you have to do something destructive to the nerve. And those include any of the percutaneous procedures like, using glycerol or a balloon. Those are pretty much equivalent radiofrequency. It actually is a little bit more durable, but it comes with a good bit more numbness. Gamma knife or stereotactic radiosurgery. Those are all have advantages and disadvantages, and you definitely want to, if you want to be speaking to someone that really understands the nuances of the different procedures. And I think it's really important when you meet with someone that person is thinking about you and how long, making a guess. This is what I do with every patient is, how long do I think this person is going to live? And while that may seem a little bit grotesque, if I'm seeing a 40-year-old and I'm looking at their other illnesses and things, and usually they're healthy, I may be thinking, okay, this person will live to 85 or 90. I have to figure out, how do I keep them out of pain for the next 40 to 50 years? If the person's 80 and maybe their parents lived into their 90s, well, then I got to be thinking about the next 10 to 15 years. But if you see someone and they just are like, well, we'll do the gamma knife and see how that goes, or we'll do a glycerol and see how it goes, I don't think, that's not great. Some of the really challenging facial pain disorders are disorders like acute herpetic trigeminal neuralgia from herpes zoster, or chronic herpetic zoster. Those, it's usually a very bad idea to do any kind of destructive procedures. They don't respond to microvascular decompression because they're not due to is this okay, Brandy, or should I just stop and take questions?
No, this is great. I
Great.
think covering the different pieces, and then if you could also touch on kind of TN2 and persistent idiopathic facial pain.
Yeah. So the post-herpetic trigeminal neuropathies are typically treated with medications and multiple medications. The difference between the acute and chronic, according to the classification, is acute means that it's been occurring for less than 3 months, and chronic means that it's more than 3 months. So, if there's someone on the line here, most likely they've had it for more than 3 months. And so sometimes they may benefit from neuromodulation in the form of a stimulator or an implanted pump or something like that. There's individuals who have traumatic trigeminal neuropathy. So maybe a neurosurgical procedure or a dental procedure or an otolaryngology procedure inadvertently injured a branch of the nerve. And so those are the kind of procedures that if there is an injury, it's best to get to the injury sooner rather than later, like in the first year or so, and have someone that's capable of excising what's called an neuroma, where the injury occurred, and then putting a graft in and putting that nerve back together. If it's after a year or two, then usually that type of procedure will not work. And then that's when we start thinking about stimulation or something like that. I'm happy to talk about glossopharyngeal neuralgia or nervous intermedius neuralgia, but Brandy asked me to address TN2. So let me address this as best I can. And not everyone agrees, but I just gave a lecture at the Congress of Neurological Surgeons where we had a symposium of about 10 speakers about TN. And some people, neurosurgeons there, still use the term TN1 and TN2. This classification schema was coined in 2003 by Dr. Burchell, and it was a very good attempt to try to classify different pains and see what types of treatments work best. But you should understand that it's really a statistical construct. In other words, people don't really have TN1 or TN2. TN1, according to the classification scheme, means that you have intermittent pain more than 50% of the time, and TN2 means that you have constant pain more than 50% of the time. So that's like a statistical way to put patients into certain buckets and see how they do with certain procedures, but they're actually not real entities. So there's classical TN, as I said earlier, and then there are lots of people with what I think Brandy appropriately referred to as idiopathic idiopathic TN, which is kind of the old term, but now idiopathic TN really means that you have classical symptoms, but you don't have a blood vessel deforming your nerve. So I see it's really confusing, but basically that the more constant pain is called idiopathic painful trigeminal neuropathy by the International Headache Society. And you might be saying, well, all these names is terribly confusing, and it is. And I wanted to go through some of these tonight, but there's a reason that these names have been codified, and the reason is that it allows researchers to say, well, we studied this particular condition, this name, and we did these types of procedures, and this is how the patients did. And so we recommend this, or we no longer recommend that. If you're talking about idiopathic painful trigeminal neuropathy, which I see every week, people used to call that, surgeons and clinicians used to call that atypical facial pain. And certainly the IHS, but a lot of us have gotten rid of using that term for a variety of reasons. But one reason is because actually more constant nerve pain is very similar to like carpal tunnel nerve pain, carpal tunnel syndrome nerve pain, or sciatica down your leg. So it's not atypical for nerve pain in the body. What it meant was it's not typical as compared to classical trigeminal neuralgia, which really makes no sense. And what I mostly don't like about the term is if you tell someone you have this diagnosis of atypical whatever, I think it makes people feel kind of weird. It makes them feel like there's something wrong with them, when in fact, it's probably the most common type of facial pain. And it's a type of facial pain that we don't understand nearly enough about. I do think, there's a new drug that's in trial right now, and while it's not, it's the inclusion criteria do not allow enrolling patients with idiopathic painful trigeminal neuropathy, or what some people call TN2. My sense from treating patients is that it is probably going to help those patients. And so I'm really excited about that new drug. And there's a number of other drugs that are going to be coming out of labs in the next decade. I can't say for sure when Noema's drug will be approved or if it will be approved, but it's probably like in the 2028 range. So that's still 4 years off. But I think that is an exciting drug that's coming. Maybe I ought to stop there and just take some questions, Brandy. That's a lot of talking.
Thank you, Dr. Scholet. No, that's helpful to kind of frame our conversation as we do start to answer questions, and people have questions about their different diagnoses. And I appreciate you mentioning that, atypical really is an other term, and it should be retired. So
yeah.
Thank you so much. Someone has a question about, pain pumps in the cervical spine. Can that be helpful for people who have facial pain?
I think it can be tremendously helpful. I mean, we published the first paper using a drug called Prialt, which we don't have any relationships with any companies, but Prialt is a trade name for ziconotide. And also the group at Case Western published using a different medication. And we've seen, a lot of help from that. The challenge is finding clinicians who will do it and put it in. It's really pretty safe. You have to go through some psychological testing for the very basic reason that they're putting this implant in you, and they want I guess insurers feel like, well, we want to make sure the person doesn't wake up and say, get this thing out of me. So it's like you have to go through a trial where you get the drug for a few days. But that can definitely be really useful. I know of at least one individual um, um, in the facial pain. I don't want to use her name, although I think she's pretty active, really nice woman in the facial pain community that has gotten a form of deep brain stimulation for facial pain and done really well. She was really suffering. So she had that done in New Jersey. And I think that's very exciting. I just saw something pop up where someone said, I cannot wait for 2028 for a drug. And I don't want to say I understand that because I'm not in facial, I don't have facial pain, but I imagine that is rather deflating. We don't know. The company may have to do a third trial, and that they may open that up to patients with um, with with other forms of TN. And if that third trial comes, it may come like as soon as within a year. So that could be exciting. I don't know. I think you may be having something with Noema, right? And they could probably field some of those questions.
Yes, we actually had a webinar with them a few weeks ago, and during that, I'd heard a potential second in 2026, I believe. I'm pulling
Okay.
from memory here, but we can share that information with the group as well. And some people had questions about, what is BiM Grant? We have additional information on our website and also as part of that prior webinar, which we can share.
The only thing I'll say about that is
Mhm.
it's a completely different class of medication than probably anyone on the line has taken. And so it works on the glutamate receptor. It's a certain type of agonist that helps the receptor bind more glutamate. So, it's a very interesting drug. I didn't have as high of hopes for it as I do now before I started enrolling patients, but I've enrolled about 10 patients, and I think 7 of them have done extremely well. And I've taken them through the whole, it's almost like a 1.5 year process. So it's kind of exciting.
Thank you for sharing that, Dr. Scholet. Is it, the way the medication works, and just from hearing them speak about it, reading and hearing what you've spoken, is it similar to how some of the newer migraine drugs like the CGRP agonists or antagonists work, where latches on to, instead of, I guess, CGRP, it'd be glutamate? Is it a similar type of mechanism of action?
Yeah, it's referred to as like an allosteric modulator. So it latches onto a receptor and then makes the other receptor have more affinity for binding the molecule. So it's a very different class. And the other exciting part about the drug is that I haven't seen much in the way of side effects. Patients are not feeling the way they do with carbamazepine or oxcarb. Yeah.
Thank you.
I mean, I just had a fella in my clinic yesterday, and he said that, we did a microvascular decompression on him, and he is basically pain-free with medications, which when we rate it, we don't rate that as a success. He is better, I guess, than he was before surgery. But, in talking to him, and he may even be on the line tonight, you can tell, and I talked to his wife, you can tell that the medication is having a toll on him, that he doesn't have the kind of recall that he normally would have, and that he's, kind of tired a lot at home and things like that. So these drugs can be, I'm not putting down the drugs. Some people do really beautifully, and I wish surgery helped everyone. It does not. But these drugs can be really tough for patients.
Yes. They can. And we've had a lot of comments about, what can I do if I've exhausted my medication options? One question that's come up is, if you do or know of anyone who does kind of the intrathecal pain pumps.
Yes. We do have someone here at Columbia that that does them. There's pretty sure there's still a group at Case Western that does them. And I don't want to suggest that those are the only places, because there are other centers. Again, it's a little bit of an ordeal, but it can be very helpful for individuals with, let's say, anesthesia dolorosa. And again, you get the drug for a few days just before there's a commitment to internalize this system. So we think it's a pretty exciting area. And again, ziconotide is not a narcotic, so it's a muscle relaxant, and it's given in because you're putting it into the cerebral spinal fluid. You put such minute quantities that the individuals, they're not feeling adverse effects from the medication typically.
Mm. Along those lines, not necessarily a pain pump, but, one chapter in the book I know is on ketamine. Could you talk a little bit about, ketamine and how that's used to help people with facial pain, your thoughts?
Yeah. Well, one of our medical advisory board members, Ken Casey, was probably using ketamine as early as maybe 2003 or 2004. And he was really way ahead of the curve. He probably has, certainly on the MAB, has the most experience with that. How ketamine works is not really clear, but patients can receive small doses of ketamine and have some prolonged remission from pain. It's something that has to be repeated, in an infusion center every so often, but it's definitely something that can be tried. I had something that I was wanted to mention, but okay, that's fine. But yeah, ketamine is an interesting drug. I haven't seen much success with Suboxone, for example, for facial pain. I think there's a limited group of people who benefit from, let's say, Botox for facial pain. As much as I think acupuncture can be really helpful for a number of different medical conditions, unless people welcome to jump in here and say, "Oh no, it worked great for me." I haven't seen acupuncture be particularly helpful for facial pain, different facial pain types.
I'm going to jump in for a minute.
Please do.
And say it worked for me for a while I was doing it. And I think the thing is, I've had a couple of MVDs. I've taken probably every medication in Dr. Lipka's table. And in the end, if you've been living with this for a long time, there is no magic bullet. So you have to kind of take a Swiss cheese approach to this. So imagine you're making a Swiss cheese sandwich. You don't want to see any holes, any bread showing through. So you just put different layers of cheese on the sandwich, and those are the different things you do. So you might do mindfulness, you might do acupuncture, you might go to exercise class because you find when you're more active, you get the endorphins going, and that's better. For some people that doesn't work, but I think you find the things that work for you and you just layer them on and do a host of different things, because it's the combination that keeps you pain free. So will acupuncture alone work? I don't think so. But will it work with other things? Absolutely.
Yes.
Yeah, you're someone living with it and understand. I just presented, we haven't published this yet, but I just presented our results for microvascular decompression. Let's say for the best candidates. That doesn't mean the best people. That means people with classical TN, arterial deformation of a nerve, and response to carbamazepine early. And at an average follow-up of 6.5 years, which is pretty long in this world, it's about 83%. When we looked at it at 3.5 years, it was about 93%. So there's a fall off. And the reason I bring that up is, as Anne said, there's different, you have to kind of layer different things. Microvascular decompression, and that's not what I really wanted to talk about completely, but it can be curative for a whole host of people. For certain candidates, that group, it's probably 75, 80% lifetime chance of being curative. But that probably doesn't encompass a lot of the people on this call tonight. One of the treatments that we've been doing a lot of for patients with, let's say, different forms of TN that we haven't had much success with other procedures is just blocking the trigeminal ganglion in the operating room with a mixture of a steroid and bupivacaine, which is like what you get from a dentist. And we looked at our results in a couple of hundred patients, and this is a real mixed cohort of patients. There's a lot of different type of patients. A lot of those patients with what you call TN2 or idiopathic painful trigeminal neuropathy, and the average length of relief is 6 months. So some people say, well, 6 months for an injection. Well, if you have pain, I think that's a long time for some people. And some of these people, we still have it still working 2-3 years after just one injection. So
Wow.
that's something I've been doing for about, I don't know, maybe 5 or 6 years, but I haven't talked about it much because I needed, ample follow-up time to really see how we were doing. And there are people that it just doesn't help at all. There's people it helps for 2 weeks, and obviously that doesn't make sense. But the average has been about 6 months, and I've been sort of excited about that because it's not destructive. It does not injure the nerve.
That is fascinating. Thank you for sharing that.
Yeah.
That's a new way or new consideration.
So for example, if I get a 40-year-old, let's say I get a 40-year-old in my clinic and they don't have classical TN and they've got a lot of pain, and you don't have to prove to me you're having a lot of pain, but it's clear they're having a lot of pain and the medications were working or never worked. I look, they don't have a tumor causing their pain. Again, they don't have classical symptoms. That's usually my go-to because if I have a 40-year-old, again, I have to be thinking about this. I make an assumption she or he is going to live to 90. I don't want to start doing destructive procedures. And if you have more constant pain, usually the destructive procedures don't work. They often will make it worse.
Thank you. I know you touched on MVD and you were saying that really wasn't part of the conversation tonight, but this is a question that we see frequently from people is, they've had an MVD, it was successful, now the pain's returned, they're considering a second MVD. How do you approach making that recommendation or decision? Even if you do visualize, a compression on an MRI.
Yeah. So let's assume you're, and again, I just want to repeat, this doesn't make you a good or bad person. Let's just assume that originally you were an ideal candidate for MVD. And an ideal candidate means you have sharpshooting, electrical, whatever you want to call it, pain. I'm just being quick because we don't have all night. That's, really shocking, worst pain of your life. It's memorable. And it responded, let's say, to carbamazepine initially, and the MRI, if it was recent enough, let's say in the last 10 years, showed an artery compressing the nerve. And you had the MVD and it worked for 6 or 8 years. But now it's come back, just like I said, at our 6.5-year average follow-up, if we look at 100 patients, 83 are still pain-free, but that means 17 have had some amount of a recurrence. It doesn't mean 17 are in agony. Some are pain-free on 200 milligrams of carbamazepine, but some are in agony. And so what we do is we re-image them first off and find out, is there a blood vessel? Now, typically there isn't. There's this idea that veins grow back and things like that. That I don't agree with that. There are some surgeons who say they do. So it depends. If it's somebody that's, I don't know, 60 or 70s, I might try something destructive like once, like a glycerol, because sometimes you just need one extra procedure to sort of get you over the line. And that can work for a long, long time. If it's somebody younger, it's possible we would go back and just sort of massage the nerve, not really do what's called an internal neurolysis and separate the fascicles, because that's fairly destructive. So we might do that. Again, we're talking about the worst cases where they're not managed on a low dose of medication. That's generally how I approach it. Let's say the person did have classic TN and they came in and the blood vessel's well decompressed and it's been 8 years since surgery, and now they say, well, hey, we have this new drug. Do you want to try it? And because you're going to get it for almost 1.5 years, and they might say, yeah. And things are dynamic. You might finish that drug trial, and then we've had a couple people come through that trial and they're no longer having pain. They're off of the drugs.
Wow.
You
Is
know,
it to kind of help kick off a remission, or?
I don't think the drug is curative, but
Yeah.
you know, it's just such a dynamic process, facial pain, that if you have it today, there's nothing to say for sure you're going to have it 5 years from now. You know, people do get through it sometimes, and things change.
That is fascinating. Well, I want to be respectful of everyone's time. And so I'm going to give a final question to you, Dr. Scholet, and then I'm going to actually welcome everyone kind of to respond and maybe give their thoughts as well. What would you say are the key takeaways for patients and caregivers to remember when they're considering various treatment options for TN? And how should they approach discussing these treatment options with their doctor? So whether, depending on where they're at, what would be key takeaways?
Well, I mean, I want to be clear. I don't have TN. And even though I've treated thousands of patients with it, if I had it for probably an hour or a day, I'd probably have far more insight into the problem than I do. But with the experience that I do have, I think connecting with an organization like the FPA can be really helpful, because the FPA has a really good staff and volunteers that are really interested in patients' well-being, and you can get some excellent information through the organization. I think a lot of patients are unfortunately trapped in neurologist offices, and they're just getting medication, seeing their doctor every 3 or 6 months. And some of those patients, or maybe many of those patients, can really be cured with surgery. And now, again, I wish it were better, but the big ones for cures are classical TN, idiopathic TN, MSTN, and TN due to tumors. But there's a lot of hope for some of these other conditions, like if you have a nerve injury, that may be able to be the neuroma, the abnormal tangle, may be able to be resected and put back together. As we talked about, you may be a candidate for a pump with an Prialt, or it can be a narcotic like morphine. You might be a good candidate for a stimulator, which again is not injurious and can kind of just trick the brain. It sends sort of phony signals through the nerve up to the brain. And then again, I guess my final take home is that, as a patient, you should get this. The person you talk to, it's not that they need to spend an hour with you in a meeting, but you should get the sense that they really want to hear your whole story, that they don't need to just look through your chart. They should really want to understand, when did this begin? What was the character of the pain? How did you do with certain drugs? And kind of take an interest in you, and not just say, I mean, there's some people that, yeah, you're a perfect candidate for surgery. Let's do it. You're having pain. But some people, you have to really dig into it and try to figure it out. And I think it's helpful to see someone who really understands the conditions, at least as well as we can understand them.
Absolutely. And, it's not just your expertise, but also your humility and the humanity that you bring to it. Respect you so much, Dr. Scholet.
Well, thank you. I'm awfully sorry about the slides tonight. I give
That's
presentations.
okay. We can schedule. This has been a great conversation, and we can schedule another time to do your slides, and then we can add it to the list, and no big deal.
I jotted down 5 notes when you asked the question. And Dr. School, I don't think you need to have TN for an hour a day to be able to treat patients effectively. So,
Thank you.
No, don't go there. So my 5 takeaways are: go to an expert. Don't go to the neurosurgeon down the street who has never done an MVD or has done only one in a lifetime. Go to someone who does them all the time. Get plenty of support. Ask your family, ask your friends for support. Believe me, they want you to feel better. And you can do so much when you have the support of people around you. Stick with evidence-based medicine. Don't go out on limbs trying things. For the most part, there's a small set of things that work, and that's what you should stick to. And the last 2 things are related. Don't give up. there is something out there, and if you don't have the stamina to look for it, your support person can. And if you're feeling like you want to take your own life, seek help, because I would bet that every person out there who says they have suicidal thoughts really doesn't want to end their life. They want to be out of pain. And that can happen if you get yourself in the right hands. And the FPA is a great place to start.
Well said, Anne. There is hope. Absolutely.
Absolutely.
And Dr. Greenberg, any key takeaways that you have, for people living with facial pain or caregivers who are battling this, and especially, as we go into the holidays, which can be a particularly difficult time of year?
And I'd just like to say one thing about Dr. Greenberg before he answers. And I mentioned it earlier, but we're really fortunate to have someone like him, as talented as he is, dedicating his resources to this condition, because, just 10 years ago, there was no monies being directed to trigeminal neuralgia through the NIH, and Brandy and others are really helping. And that's going to be huge. I mean, so, if you don't want to participate with him, that's perfectly fine. But if you can and you have the energy to do it, you're going to really help a lot of other people. Sorry, Dr. Greenberg.
I appreciate that so much, Dr. Scholet. Yeah, so key takeaways, as we said, you are not alone. There are plenty of resources available. I know that sometimes it's very understandable to feel that you've tried everything and there's nothing and there's nothing left for you. And even just scrolling through the chat, it's really profound, and I'm getting emotional just reading through it. Like people, I've lost everything, and people really sharing their experiences. So there are, and I think the FBA is doing such a wonderful job of conveying that there are support groups. Talk to other people. When you talk to other people, especially those that are in a similar boat as you, have a similar condition as you can build off each other's strengths. You can build, you can share resources. You can get the support. Talk to your family. If you talk to a therapist, go to Psychology Today. So just find a therapist near me. If it's 3 a.m. and you're like, oh, I just can't take this anymore, call 988. They're there 24 hours all the time. So even though you might feel like you're alone and you've tried everything, there's always people to support you. There's no magic switch to take your pain away, unfortunately. But you can live. Many people have found a way to live a good life with these conditions. And so even though, just trust yourself when you think there's no other choice, there are other things that you can try and people that can help you. That's my key takeaway.
Absolutely. And you can always give us a call. Thank you so much for being here with us tonight to kick off Facial Pain Awareness Month. And thank you, Dr. Scholet, Dr. Greenberg, and Anne. It has been an honor to spend the evening with you.
Thank you.
Thanks for
Thanks
having
so much, everyone.
Absolutely. Thanks. Have a great night, everyone.
Thank you. You too.